Good morning, ladies and gentlemen. On behalf of Department of Internal Medicine, I welcome you all for today's Saturday clinical meeting. Today, we'll be presenting a case of 30-year-old serving soldier who was a known case of immunosurveillance with opportunistic infections and who has been initially treated at Journal Hospital and again presented with respiratory symptoms in August 2023 at Command Hospital, Bangalore. Subsequently, he was referred to Pune complex for further management. So we'll be discussing an approach to such a case, highlighting the newer shorter oral regimen of and recommendation by National Tuberculosis Elimination Program about the new regime. So without much ado, now I'll request to proceed with his presentations. Yeah, Squadron Leader Abhishek.
Morning, sir.
Yeah, so any undergraduates will start from quiz. Can you just identify who all are these dignitaries and what is commonality in them? Anyone? Undergraduates can take over this question. It's quiz. I can give you hints. Some of them is mathematician, Nobel laureate. Yeah. Any postgraduate? Yeah, Rajesh. Yeah, please give the mic. Yeah, keep telling.
So this is Nelson Mandela, Srinivas Ramanujan, Muhammad Ali Jinnah.
Okay.
Rest. The common thing is they all
Two more.
That is Louis Braille.
Yeah. And why he's famous?
They all probably contracted tuberculosis and died of tuberculosis.
Okay, so right. So community is basically all of them, they suffered from tuberculosis at some point of time in their life. Okay, proceed.
My patient is a 30-year-old male serving soldier, resident of Tamil Nadu, educated up to 12th standard, and informant was self and reliability was good. He presented with chief complaints of cough of 1 month duration, shortness of breath for 1 month duration, and fever of 2 weeks. Cough was productive, was scanty and mucoid in consistency, was non-blood stain and non-foul smelling. It was about 1 to 2 teaspoons with each bout. He had no postural and diurnal variation, and no specific triggers like dust, smoke, or cold were present. He also gave history of incident onset gradually progressive breathlessness, which initially was on walking uphill, which now presently had worsened that he had to stop to take rest. There was no history of orthopnea or PND. He gave history of fever of 2 weeks duration, which was intermittent, associated with chills, and evening rise of temperature was present. This was associated with an unintentional significant weight loss of about 5 kgs in last 1 month and associated with decreased appetite. There was no history of dysuria, increased frequency of micturition, pain abdomen, loose stools or vomiting, no history of chest pain, palpitations or syncope. There was no history of jaundice, difficulty in swallowing, abdominal distension or bleeding manifestation. There was no history of rashes, ulcers or joint pain.
Just hold on. Yeah, any first year? Just tell quickly why you want to rule out this history. Yes. Why this history is relevant?
No history of dysuria, increased frequency of micturition will pertaining to be a urinary tract infection, sir.
Okay.
In pain, abdomen, loose stool can point towards GI.
Why these night sweats and all?
Vomiting and night sweats again in a setting with the patient having cough for last 1 month will again point towards either a tuberculosis infection. And no history of chest pain, wheeze, palpitations, and co will be pointing towards a cardiac cause. No history of jaundice, dysphagia, abdominal distension, bleeding manifestation, constipation. And
you just tell what we want to rule out. Don't just read it.
Sir, again, GI cause.
GI symptoms.
Yes, no
what about these rashes, ulcers, and joint pain?
Can be multi-system involvement in rheumatological disorder.
Yeah, right. Proceed.
In 2017, patient he had initially presented with history of fever, hemoptysis, and weight loss, and he was diagnosed as pulmonary tuberculosis. At the same time, he was diagnosed with as immune surveillance, and mode of infection was not known. His spouse also tested positive for immune surveillance. His CD4 count at the time of presentation was 244 cells per cubic millimeter, and when the latest CD4 count was 282. He was also a case of alcohol dependent syndrome for which was upgraded to shape 1. There was no history of any diabetes, major surgeries in the past. He consumes mixed diet. He gave history of consumption of alcohol about 60 grams per day for 5 years. However, he claims to have quit for the last 5 years. There was normal sleep cycle, normal bowel and bladder movements. There was no history of blood transfusion or tattoos, and he denied history of high risk sexual behavior.
So Abhishek, just hold on. Yeah, any second year, go back to the previous. He is consuming 60 grams per day for last 5 years. So what is the serogenic dose for male and what is for the female? Yeah, Akash.
40 to 60 gram per day for 10 years for male, and half of that, that's 20 to 30 gram per day for 10 years for female.
20 to 40 gram
per day for 10 years for a period of 10
10
to
to
12
12
years. 12 years
for the female.
female.
Okay. Why female has the threshold is more in case of male than female?
So the metabolism of alcohol is lower in females, sir, because of the lower levels of alcohol dehydrogenase. So they have higher effects of alcohol at the same level of consumption.
Okay. All right. Take your seat. Proceed.
His spouse had also tested positive for HIV in 2017, and child HIV status was negative. There was no history of no family history of tuberculosis. Patient was exhibited on TLE regime, that is tenofovir, lamivudine, and efavirenz. However, he had poor drug compliance and he had skipped medications for last 3 months.
Okay. Any second year? Prince, can you summarize?
A 30 years old male serving soldier, known case of immune surveillance, detected in 2017, and at the time also detected to have pulmonary tuberculosis, completed 6 months of ATT in 2017. Now presents with history of poor compliance to ART medication, following which he had history of cough and breathlessness on exertion MMRC grade 2 for 1 month duration and fever of 2 weeks duration, with significant weight loss and loss of appetite.
Okay, right. So at this point, what differentials would you like to think of?
Sir, in the setting of a patient with immune surveillance with poor compliance to ART and history of TB relapse would be my first differential.
More common before that, would you like to place something?
Opportunistic infection because patient was not taking ART and was poor compliant, and community acquired pneumonia.
Yeah, community acquired pneumonia should be the one. Then tuberculosis is also other possibilities. And of course, HIV with the respiratory OIs would be one of the possibilities in this case. Okay. So, can you just tell association between the CD4 count and common opportunistic infections? Babu, Major Babu, keep passing your mic.
Sir,
So this is based on the count. So quickly tell, what is the association between CD4 and common opportunistic infections?
sir, the CD4 count is less than 400. The patient can have a herpes zoster infection. If it is less than T350, sir, the patient can have a tuberculosis and PCP pneumonia, sir. If it's less than 200, then the chance of toxoplasmosis infection, sir.
Less than 50?
MAC infection, sir.
And anything else? CMB.
CMV.
CMB can be there. So what about a specialty about the TB and lymphoma? I've given a statement, then what do you want to say about this as per the new guideline?
There's an increased chance of
No, so they can happen at any CD4 count. What they can happen at any CD4 count. Okay, so this is as per the latest guideline. Okay, proceed. So how you are going, what is the treatment of OIs and how you are going to initiate the ART treatment?
patient has tuberculosis, then ATT should be started first, and ART should be initiated after 2 weeks of initiation of ATT. Unless the patient has TB meningitis, in that case, it should be started 4 weeks after the initiation of ART.
Close your mic.
In case of
Be loud.
in case of cryptococcal meningitis, then the treatment should be ART should be initiated after 4 weeks of initiation of ART.
Okay, so these three things are important in tuberculosis, cryptococcal meningitis, toxoplasmosis, and PCP. In PCP, you need to treat first PCP, then start ART when PCP treatment is completed. In cryptococcal, 4 to 6 weeks from the initiation of antifungal treatment. And for toxoplasmosis, you need to treat toxoplasmosis first, start ART after 6 weeks of treatment when patient is stabilized. So these are the commonly opportunistic infections which we have been encountering in our day-to-day clinical practice here also. Okay, so this treatment of these particular OIs we should be aware of. What is treatment failure? Next to you. Yeah, Major Ram.
So treatment failure, we have three types of failures: so clinical, immunological, and virological, sir.
Okay.
Sir, in clinical failure, sir, after 6 months of initiation of ART, patient has new infections of WHO clinical stage 3 or 4, sir. Sir, immunological failure is said when the CD4 count is at below 100 after 1 year of ART, and virological failure is viral load more than 1,000 copies even after 6 months of ART with 95% compliance.
Okay. Next. So what are the OIs prophylaxis which we are supposed to start in these subsets of the patient? Dr. Shweta?
So most commonly according to CD4 count, if the CD4 count is commonly it's less than 200, we start on PCP prophylaxis.
Which agent has to be used?
Give Septran, sir,
Okay.
which can be given double strength daily or single strength also. If toxoplasma IgG is positive or if the CD4 count is less than 100, then we can start prophylaxis for toxoplasmosis, which is also again Septran. And we can also give prophylaxis for MAC if CD4 count is less than 50. We usually give tablet azithromycin 1200 mg weekly or 600 mg twice weekly. Also, sir, we can give for a PCP prophylaxis should also be given in case of nocardiosis or for bacterial pneumonias to prevent that. And it can also be given during TB treatment, during the entire duration of the TB treatments.
Okay. Next to you, Dr. Karthik is there. So when to stop these OIs? You have started the patient. So when you are supposed to stop this?
For PCP pneumonia, sir, if the CD4 count reaches above 200, then
Okay.
indication is not required, sir.
Okay, right. Next. So this is again when to stop the OI prophylaxis. For PCP, may stop prophylaxis if CD4 count is more than 200 for more than 3 months. For toxo, may stop prophylaxis if count is more than 200 for more than 3 months. And for MAC, may stop prophylaxis once ART is supposed to be started. Next.
In examination, my patient was conscious and oriented to time, place, and person. His BMI was 17.64 kg per meter square, with a height of 170 centimeter and weight of 51 kgs. He was febrile with temperature of 101 degree Fahrenheit. He had tachycardia. His BP was 100 by 68 millimeters of mercury, and he had tachypnea with respiratory rate of 28 per minute, and he was maintaining SpO2 of 94% on room air. He had pallor and palpable lymph nodes. Cervical lymph nodes in the right level 3 and left axillary lymph nodes were palpable. The size of the cervical lymph node was 1 into 1 centimeter, and axillary lymph node was about 2 into 2 centimeters. They were firm in consistency, non-tender, and matted. They were free from the underlying structure, they were mobile, and the skin over the structure was normal. There was no icterus, cyanosis, clubbing, or pedal edema. No peripheral cutaneous markers of tuberculosis or HIV were seen. JVP was not raised.
Okay. Some of the undergraduates can take over these questions. We have been already mentioning this thing. Yeah, Adarsh, can you just identify quickly? What are these lesions? These all are the peripheral stigmata of tuberculosis. So what is this lesion? Quick.
So the first one is lupus vulgaris.